All right. Well, hello, everybody. It's good to see all of you. Thanks for coming. I'm really thankful to everyone who helped arrange this and convinced this many doctors to come out after a busy day. I know how hard you work, all of you, primary care, and I know there's some other kinds of practitioners in the room. So I'm really grateful. Trust me, when I've tried to fill this room to talk about all kinds of topics, and we have never once filled it, to talk about something substantive, which tells me, just confirms what I've always known, which is we have a significant healthcare crisis in our state, and within that crisis, we have a crisis of primary care. And they're kind of feeding off one another, unfortunately. So, you can see from my fabulous book here that I have no agenda at all. And that's by design. I was hoping that we could just have a conversation about the challenges you see in healthcare, things that we could do using our bully pulpit to advance fixes. We've had some success in that recently with our effort to raise reimbursements for primary care for Medicaid to Medicare, which we hope will at least advance the ball somewhat. We know it's certainly not the end of the larger discussion. You know, for example, we're talking in the office internally about single payer as a potential solution because the system seems in many ways and on many days irretrievably broken. You know, from my perspective, it feels like we are trying to practice medicine in a free market where the market isn't free. We have components of regulation, but none of them are comprehensive, so they don't work well together and they don't solve the problems that we face. You know, we do antitrust reviews on mergers where we follow the letter of the law as we're charged with, and yet I walk away from those decisions feeling like we may have reached a decision, yes or no. Many times it's been no, but where is the solution to the problems we see in the course of looking at those large proposed transactions, like the proposed merger of what's now Brown, then Lifespan and Cairns Mainland. And so one thing I have learned from my friend Dr. Sullivan and many people sitting around this room and people who aren't sitting here, Dr. Ryan, Dr. Chan, my friends at Landmark, who I met with recently, Hub Brennan, who's been a friend now for a long time, and many, many others. My own wife, Shelley, who's put up with me for 31 years. And before that, I knew her when she was a resident. So we have a son who's a fairly new doctor who's doing his residency now. So what I really hope from tonight is to learn more from you. We have found that the things we have advanced have come from our conversations. I see we have an emergency room doctor here. I don't know if Doctor, you were there when I met with the Brown emergency physicians about 18 months or so ago, but the emergency room physicians then told me, I said, we need a state of spectacular failure for people to wake up and recognize the crisis we're in. And the ER doctor said, well, we're boarding 50 patients a day. We already are in a state of spectacular failure. So anyway, the things that we set forth in this room a few weeks ago were frankly pretty narrow. I mean, the suit against the PBMs may drive down drug costs if we're successful, but you know, raising Medicaid and Medicare for primary care is not going to fix our system. It's not going to bring the revenue in that we need to stabilize the system. It's not going to prevent the exodus of primary care doctors or our inability to attract them. So the hope tonight is just to share some thoughts, ideas, and we really are very interested in the things that you have to say. And I hope it won't be our last conversation, whether in a group setting or one-on-one. So I thought what we do is, since I want to be respectful of your time, is go around the room quickly, tell us who you are, how you, what kind of practice you're in, and then we'll just figure out a way to begin. I want to thank, in particular, Dr. Sullivan, for whom I have a great deal of respect, for whom I have a great deal of respect, who put together I don't want to say eclectic, that's not the right word, but a broad group of physicians from all kinds of practices. We had a thoracic surgeon, we had a pediatrician, we had a primary care doctor who'd gone into concierge medicine. You, of course, are a plastic surgeon. Your wife is here, who's a nurse. We had a cardiac surgeon. We had a dermatologist. So that was a really helpful meeting for our team of lawyers to hear from people who deal with this on the ground every day. So, there are some big solutions, reimbursement rates going up, prior authorizations going down or eliminated, as we had hoped to do in this session. Didn't quite get all the way there, but got there with, I guess, Medicaid patients, right, Lee? Right. Lee is the chief of our healthcare team, and our healthcare team is scattered around, and you'll hear from them as we go around. But I hope we go around and then just start talking. And the more voluble of you will, well, I'm sure will jump right in. So, Lee, take it away.
Sure. As the Attorney General mentioned, I'm Lee Staley. I'm the chief of the healthcare unit. I'm actually a relatively new addition to the office. I came about, I think it's a little under 2 months ago, and I was previously working with the U.S. Department of Health and Human Services, where I was advising the Centers for Medicare and Medicaid Services, and I touched a number of different areas. My core focus was really drug pricing, but I also did a lot of work with the Center for Medicare and Medicaid Innovation on value-based payment. And before that, I was in private practice at a firm in Boston where we did work really across the whole range of the healthcare regulatory system. My particular specialty was in reimbursement. And so, that's the lens that I'm looking at things usually, but it's great to be here with you all. We really value this opportunity to speak with you.
Shelley Johnson, internal medicine, primary care. I was in Coastal for many years now, part of Brown. I've been practicing here for about 30 years, and I've never seen healthcare in such a crisis as it is now. And Peter sees me at my computer most nights just because the hours are so long for most of us, I think. And so I think that's what provides healthcare and hours in Rhode Island right now.
My name is Joy Convent. I am the insurance advocate here at the AG's office. I sit in the healthcare unit. I've been here for 2.5 years, and prior to that, I was in private practice.
I'm Pam Harrop. I'm an internist. I work at, and I'm the chief medical person at Medical Associates of Rhode Island, which has a office in Bristol and in East Providence, composed of about 18 primary care docs, a couple of nurse practitioners, dermatology, podiatry, and an urgent care. I think we're one of the larger fully private groups. We have a strong affiliation with Brown University Health, but we are fully private. And I'm also president of Community Physician Partners, which is an IPA of 180 primary care doctors, also affiliated with Brown University Health.
What's an IPA, Doc?
It's an independent practice association. So there's 180 of us who are all private. We're not part of, Care New England, and we're not part of Lifespan, and we're not, so we kind of gathered together to try to negotiate contracts with the bigger insurers. So when you say, hi, I'm Pam Harrop, and I'm representing 20 doctors, it's a whole different than when I say I'm Pam Harrop and I'm representing 180 doctors. And we just by able to say that, we recently got Blue Cross to move on our infrastructure money because I told them that there were 180 very angry doctors who were about to call you and the press and everybody else, and within 4 hours we had a contract to get ours. So it makes it, it's kind of banding together, gives you a little more juice.
You can keep using me as a really
I do,
bad
I tell you,
guy.
all the time. I'm getting sick of that.
How much nicer than people give me credit for? Go ahead, Doctor.
Sure. So I'm Peter Pagacher. I'm a pediatrician, and as of this month, I'm the immediate past president of the Rhode Island chapter of American Academy of Pediatrics. We've been in this fight for a long time, trying to make some noise about whatever we all know about the primary care problem and people not being able to get doctors, people having newborns and not having pediatricians. And that's already happening now. This is a problem. And I'm in private practice at East Branch Pediatrics. I've been there for over 20 years. Started off as a Navy doctor. That was fun. But I grew up in Rhode Island, born in a little lying-in hospital. So I came back home and practice here now. It's been over 20 years, and I'm also affiliated with what used to be an IPA. It's more like an ACO, like all these weird names that we use, but it's an accountable care organization, which is Rhode Island Primary Care, which is a group of independent pediatric primary care practices, adult and pediatric.
Yes, I'm Greg Fox. I'm also a pediatrician. I work in a small independent practice in East Providence. I'm also past president of the AAP and the advocacy chair. And so I've been working really hard to get the voice of pediatrics into these types of discussions over the last few years, because pediatrics is especially vulnerable for a couple of reasons. One is that 50% or more of our patients are Medicaid payment plans spread out throughout the state, thanks to Right Care many years ago. And our, there's only 250 primary care pediatricians in the state, and our statistics from the survey we did last year shows that we're about to lose a net 50 in the next 5 years, unless we can kind of turn the ship around, retain some physicians, and attract some new physicians. So, we're at a particular point of crisis/vulnerability. So, I'm here to spread that word.
Hi, I'm Marty Kurzer. I'm currently the Senior Medical Director for the Prospect Provider Group, the IPA for the physicians. Prior to that, I was 42 years in family medicine in Warwick. I retired from clinical medicine about 3 years ago and took a position as the medical director. We represent 110 primary care physicians. Previously, I was part of Rhode Island Primary Care at Integra. Served on the board in Integra, as well as medical director for Rhode Island Primary Care. So I've been through different systems of care. I was in private practice, small practice, and eventually joined the last couple of years of my practice working for a hospital-based system. Commitment is to retire and become a medical director. But we represent 110 primary care doctors. We have a big focus on value-based care now at Charter Care, and enjoying some of the challenges.
Thanks, Matt.
Good evening, everyone. Thank you all so much for being here. My name is Julia Harvey. I'm a member of the healthcare team here. And prior to coming to this office, my background is really a mix of focusing on health disparities and health equity, and also value-based care.
Hi, I'm Kim Probert, nurse practitioner. I think I'm maybe the only advanced practitioner here, so I'm proud to represent. I work in primary care, Brown University Health Primary Care. Started at Coastal and kind of went through the transitions with them there. And I have a unique role. My roles kind of changed over the years. About 1.5 years ago, I started being a primary care provider myself.
Great.
Catherine Coolidge. I was internal medicine primary care. Joined Coastal. It was Coastal about 9 years ago. Now Brown Health. Actually worked with Kim. And prior to that, I was a hospitalist for about 8 years at Rhode Island Hospital. And so I joined when it was, Coastal, more physician run and owned. So I've seen kind of the last 9 years. I'm probably one of the newer people in this room, but significant change just over the 9 years that I've been there. So it's been interesting to see.
Hi, good evening. I'm Rachel Hoffman. I am a dermatologist. I recently joined Brown Dermatology, but prior to that I was working for 6 years in a multi-specialty group in Massachusetts. So I come here as a newcomer to Rhode Island healthcare recently and kind of have a fresh perspective, hopefully. And I also kind of have seen kind of the difficulties in this state of finding a primary care doctor, both personally and for my patients, and how that affects all doctors across the fields. And so I'm happy to be here to speak with everyone.
Everyone, I'm Beth Cronin. I'm the division director of our general OB/GYN division at Women and Infants Hospital. So oversee a group of, I don't know, 30 physicians and probably 10, 15 advanced practice clinicians. And I'm also the Rhode Island section chair for the American College of OBGYNs. While we are not direct primary care providers, we become that for a lot of patients in default during their pregnancy and that's kind of where the person people are seeing because they can't get in to see a primary care doc. And it's become harder and harder to kind of match up and figure out how do you get somebody once you've made all of these new diagnoses. So I'm really glad to be part of the conversation.
Thanks, Doc.
Joe Mazza, I'm a cardiologist. I born and bred here in Rhode Island. I wasn't smart enough to go to Brown, so I went to GW and came back. But I did get my training here after that. I am in a private cardiology group. We have 12 cardiologists and 4 mid-levels. We cover from Landmark all the way down to Westerly. And the struggles are the same. The struggles that primary care docs have are the same struggles we have. We can't hire people. We get outbid every 2 seconds, even internally within the state. I mean, we just don't have the funding that Brown's going to have to actually pay people. So it's difficult. I mean, we can't get people in quick enough in the office. I mean, there's always a wait. Reimbursement is an issue, but also is the pre-auths and stuff, and I'm glad that some of that is actually gone. The other hat I have is I work with Dr. Kurzer. I'm the chairman of the Charter Care IPA. One thing he forgot to say is we actually have a bunch of specialists also. There's about 300 specialists and 110, 120 cardiologists. I mean, not cardiologists, insurance. We work together. I mean, that's the difference between, I think, this IPA that Dr. Kurz and I are part of. I mean, the specialists work in tandem, and I think it is very value-based. We're the only group taking risk right now, and we're able to manage the risk and actually give back to the patient and also to the people who actually contribute to try to give them more. Not easy, but with the team behind us, we've actually done pretty well over the past several years to do it. It's getting tougher and tougher, and I think that change of getting doctors together, I think this is great. They're getting doctors together. Someone asked me a long time ago, why would you want to be chairman? I said, we'd rather help drive the bus than get run over by it. And unfortunately, that's what's actually happening. We're actually getting run over by it. But that's it. Thank you. Thank you for having us.
Thank you, General. Thank you all. My name's Hub Brennan. I'm an internist in private practice in my hometown in East Greenwich. I like to say a fiercely independent private practice. There are 5 of us. I have 4 terrific colleagues, and I try to remain active in this discussion and try to help any way I can. I am a member of the Health Insurance Advisory Council, that is a small council that advises the Office of the Health Insurance Commissioner and the Commissioner himself. And also I am on the board of the Rhode Island Primary Care Physicians Corporation, which is a 150-member independent practice association, and have been again for about 30 years. And then just a couple of quick comments that, for me, 2 very remarkable things have happened. One is that primary care doctors have become rare. Who would have ever thought? We were a commodity coming up. There were plenty of us, always undervalued, the redheaded stepchild of the medical profession, and we've become rare. And I'm hoping that society always values things that are rare, the rare diamond or the ace baseball pitcher or whatever it is. The society attaches value to that, and my colleagues and I are just hoping that maybe that'll come true here. The other very remarkable thing that has happened here is, they say when you're ready to learn, a teacher will appear. And in this case, when we're ready to fail, a bit of a savior will appear, and that's been the general and his excellent staff. And I don't mean to placate here, General, but this has become ground zero. This has become the place that fully understands what we're all about, fully understands the details of payment reform, different payers, prior authorization, referrals, all of the nuances. When we meet with your staff, there's not a lot we teach them. They know it. They know it cold. And that doesn't happen anywhere else in the state. So that's the other amazing thing that has happened, is you and your staff are throwing us a life ring more than figuratively, so thank you for that.
Yeah, that's great.
Hi, Greg Allen. I'm also primary care in East Greenwich. I'm with a group called Archers Medical. It's about 40 providers over 9 locations from Cumberland down to Westerly, including 3 urgent cares. Also happen to be the president of the Rhode Island Society of Osteopathic Physicians and Surgeons. My comment is, I've had the opportunity through my career to be in a small private practice, be in a hospital practice through charter care, joined a practice that was acquired by a private equity firm, later acquired by a national firm called Village Medical, and now back to an independently owned physician-run organization here in Rhode Island. So, having seen all of those different angles, I think gives some perspective on what's going on here. I appreciate the discussion, and I really appreciate the invitation. Thank you.
Yeah, sure, Doctor. Thank you.
I'm Sarah Rice. I'm Deputy Chief of the Civil Division, and I oversee the Public Protection Bureau. And earlier in my career in Maryland, I was counsel to the Maryland Medicaid program and also implemented the Affordable Care Act at their health benefit exchange.
Sarah knows a lot about health. She's really terrific, as the whole team is. But as a leader of the group, she is understated and very, very qualified. I'm grateful to have her here with the whole. Doctor, good to see you again.
Good to see you as well. Dr. Garen Lamp, I'm the Chief Medical Officer of Landmark Hospital, and I have a small outpatient primary care practice in some skilled nursing facilities, subacute rehab and acute rehab in the state. Very small compared to a lot of the other groups here. I employ about 7 providers, give or take, with the per diems. My kind of piece to this is, I was a little bit integral in kind of developing the new residency program up at Landmark Hospital, which has been very successful. We now are going to be moving up to 41 residents. Hopefully some we can turn into primary care docs in the area, and also involved with the Thunder Miss people to develop a family medicine residency program, which we're hoping will start next July. So thank you for the invitation and look forward to more good conversation.
My name is Gary Bliss. First off, I am not a doctor, and my high school biology teacher will be very pleased to hear that. I work for the IPA that Dr. Kurzer and Dr. Maza work for. I'm the Director of Government Programs, so that means that I manage our Medicaid accountable entity and also our Medicare ACO. And I would just say that we have been able to, in value-based risk arrangements, been able to do some very innovative work and deliver high-quality care to our patients and support the providers in doing that. It is challenging. It is getting harder and harder, but we have been able to accomplish some good things. And in particular, I've been very active in the area of health-related social needs, also in greatly expanding our integrated behavioral health, bringing behavioral health into primary care and also bringing it into care management. The head, as a former boss of mine, Patrick Kennedy, said, the head is connected to the rest of the body, and we need to start treating folks that way.
Hi, I'm Adi Goldstein. I'm the Deputy Attorney General. Also in my free time, I want to be a doctor. Most of my family are physicians, so I feel like through osmosis I can just freely diagnose and give medical advice to my family members, which probably has not worked out well for them. But I've learned a tremendous amount working with the healthcare team at the Attorney General's office. It's been a real pleasure to embark on this journey with the Attorney General and the team and do work that is so necessary for this district, as well as from all of you guys who've been wonderful partners. So thank you.
Thanks, Adi. Couldn't do it without you, my friend.
I'm John Gaines. I'm an internist. During the Mesozoic era, I was a resident at Brown. I was chief resident at Brown. You were a wonderful medical student and resident, Dr. Maza. I just want to give him a shout out. We then went into practice, and ultimately a bunch of us, not unlike the mob families in New York, came together to form a single group, and that was Coastal Medical about a quarter century ago, and that was physician-run, physician-operated. And several years, 4 or 5 years ago, we were bought by Lifespan, and more recently, we're now Brown University Health. So, been here for 40 years, and the basic issue is for those of us who are training residents and medical students, none of them are going to go into internal medicine and practice general internal medicine because money. You can make 13 times more going into a surgical subspecialty. Now, it wasn't always the same, but it was a factor of 2. So my daughter-in-law is an orthopedic surgeon in an Ivy League school. I mean, and the medical students who come through our office and residents, they absolutely positively are not going to do it as much as they may want to. They're not going to do it because they can't afford it. And if you only have people who are volunteering or independently wealthy or for whatever reason touched, it's not going to work. So in the long term, I think the only way we're going to know what's going on is to ask ourselves, well, what are the Brown University medical graduates going into? And as long as they're doing anything but primary care, we know that this is not going to work even long term. So short term, yes, you have to do something about reimbursement, it's awful. But long term, you can have all the medical students and all the medical schools you want. We have a wonderful medical school. None of them stay here. And if you say, well, we're going to make them stay here for 2 years, it takes 2 to 3 years to learn what you're doing when you get out of residency. So, I mean, everything I've read that is currently being proposed by others doesn't make any sense in terms of what the actual diagnosis is that graduates can't afford to do primary care.
Thanks, Doc.
Hi everyone, my name is Farron Fuquay. I'm the policy analyst with the office, so I work alongside the rest of the policy team, focusing on all the different aspects that we work on in the office day to day. So thank you all for being here. It's wonderful.
Hi everyone, Allison Fonseca. I'm the Policy and Legislative Counsel working with Farron and Keith on the policy team. I handle our legislative agenda at the State House, so a lot of the healthcare bills that are going through right now we're tracking and weighing in on, or working to introduce legislation like the primary care legislation that we are really happy passed the House today and hopefully will pass the Senate in the budget. But really proud to work alongside the healthcare team and the policy team and the Attorney General on some of these great initiatives, and really looking forward to hearing from you what you see as solutions or ideas for solutions going forward.
Keith Hoffman, I'm the Chief of Policy here at the Attorney General's office, but I'm most proud tonight to be here as Rachel's husband. And, I'm really proud to be the policy chief too. And actually as the policy chief here, one of the most gratifying parts of my job has been to get to work on these healthcare issues that we all see as such a challenge in our state, and to be able to, talk to Rachel about them at home, but then come back to the office and think about solutions and how we can exercise the tools that we have here to help fight for Rhode Islanders and physicians and advanced practitioners to make the system work better. So very glad to be with you all here tonight.
Hello, my name is David Lindquist. I'm an emergency medicine physician, and I'd first just like to acknowledge that I am feeling honored and humbled to be sharing this table with you all. In emergency medicine, we love to grumble about how hard our job is, but you guys have it so much harder. And I also owe a debt of gratitude to many of you here. David Steigman was my teaching attending when I was a resident in internal medicine rotations. I apologize for calling many of you in the middle of the night. And for those who I will call, I apologize in advance as well. I've been in Rhode Island for, 26 years now doing emergency medicine. And I kind of always felt like, things aren't going to change until people with money lose access to primary care. And I think that's where we are in spades. To your point, Mr. Neronha, about 50 people boarding in the emergency department, that's a flow problem. That's a throughput problem. It means there's no capacity in the hospital, which means you don't have capacity outside the hospital in terms of nursing homes. And I don't have to say to this group the most cost-effective way to take care of your population is primary care, is preventive health, is taking care of the problems before they develop. And if you don't have access to that, then you land downstream in the whole system, in the emergency department, and all we can do is try to patch the problem that has been festering. And so, we live in this place in the emergency department where we're the barometer for how bad it is. Yes, it's been bad ever since I showed up here and getting worse. And I'm grateful that you are convening this group. People, from what I understand, cannot afford to practice primary care in Rhode Island, to John's point. You cannot graduate from medical school and afford to set up shop here. You don't get reimbursed enough. You cannot pay off your loans. You cannot buy a house. You cannot sustain a family. You cannot afford to practice primary care in Rhode Island, is what I understand. You guys can speak to it better than I. That's what I see. And then we just try to help patch together the pieces. So thank you for doing this tonight.
My name's Dave Zagman. I'm a solo internist for the past 35 years. I've practiced my whole career about 2 blocks from Rhode Island Hospital in internal medicine. And I've taught medical students over the years and residents. And I think it's like the greatest job in the world. I mean, I'm puzzled by why there is not more interest in it. And the money is clearly a key issue. But there's also a lack, I think, of interest in the job. The way it's presented to people, it seems it's preventative. When you say primary care, it's kind of it connotes simple things, preventive things, yet really, I don't call myself a primary care physician. I always call myself an internist. It's interesting to hear the vocabulary around the room, but really what we do, most of us do, is internal medicine. And there's a big primary component to that, but internal medicine is kidney disease and lung disease and heart disease, and we unfortunately sort of brainwashed the lay public to think that we are just, simple
flu shots.
Care, flu shots, but we really are much more than that, and that, frankly, I think both contributes to the problems of, access and referral issues. I mean, and also the way some of these companies work. Like Coastal, for instance, is modeled on, nurse practitioners, for instance, practicing to the limit of their license, and you go see the doctor if you're sicker. But if you've been seeing a nurse practitioner for 20 years because you've never been sick, and then you get sick, who do you have to trust as a physician? You're seeing a physician for the first time or the third time. If you've been healthy, you don't want to see a general internist or what they call a primary care doctor. You want to see a cardiologist if it's a heart, or you want to see a pulmonologist. So a lot of it has to do, I think, with, or at least part of the problem is the way we define ourselves, and that's a big problem, I know. But I think it is a part of the problem, and there are a lot of I think incipient internists out there in programs and in teaching programs who, if I think they had more exposure to what some of us do, we could interest them, despite the money issues, the economic issues. And last thing I'm going to say, I'm planning to retire in a couple of years, and I reached out to someone at Kent County, the program director there, and I'm just learning about Dr. Lamp. But it would be somehow great if you guys could somehow, with your residents, could somehow connect with guys like me who are trying to pass our practices on, and maybe get someone into our offices. I'm sure you do that anyway with education, training, but boy, it would be great to, do that and get some people really interested in taking on practices.
Make sure you get my contact information afterwards.
Thank you for having us.
Thank you for having us. Gian Parikh, I changed the U to a Y, just as a joke. For the comment, I'm a urologist. For the comment down there about 13 times income, it's not the case, I can promise you. We suffer from I've been here 20 years, got here in 2005. our neighbors, the Sullivans, who I've known for, and thanks for inviting me. You know, obviously not from a primary care perspective, but more from an academic and clinical perspective, we struggle with the same thing. We have, for every one urologist coming into the community, this is nationally, you have 10 retirees. So you have a shortage of urologists, you have an aging population, so there's a huge access to care issue. And then as I have ascended in my career, I just became the chief of urology at Rhode Island Health and Rhode Island Physicians, and we struggle with retention. So we have 19 urologists every day I wake up. Someone who's in 5 to 10 years of their career, and as their kids get a little bit older and they have to make that critical decision, they are making it. Because I think as you pointed out in the news conference a few weeks ago that I was able to hear, you know, you said you go across the border and you get 25% more, and for the same procedure. So it's really a huge problem, and retention is a big deal. The other thing that's happening is the whole, you know, I don't want to bring up the whole academic medical center thing. It's like the only state in the country, I think, without an integrated academic medical center. I came here to innovate, you know, and I'm not trying to brag about myself, but we brought robotics to Rhode Island. It was a big deal. We're going to increase the cost of care. Actually, we did the opposite. We got people out now, ambulatory, less pain, a lot of great things. Kept people from migrating to Boston, to Yale, and kept them local. So that was great. But as time has progressed, it's become, something has happened where either there's lack of attention to the cries that have been out there, or something that's caused a huge issue. In urology, going on along the primary care theme, we do a lot of sort of medical management. We don't just see a patient, operate, see you later. And there's a lot of disease states in urology which require follow-up, follow-up, follow-up. We are inundated. You can't, like every day in an email to someone who mentioned people who have access, they're like, what's going on there? I can't get through, I can't get in, your phones are not being answered. So we did an analysis last week, it was 8,000 calls in like 4 days. 8,000, and I got 6 people scrambling. Do you get a call center? Do you do that? It's like, it's not sustainable. And then the reimbursements impact all of us. Obviously, I think the primary care crisis is huge. And pediatric-wise, my wife is a pediatrician, not Parikh, she's Costello. She practices we live in Barrington, she practices in Swansea. That group would never cross over the line because it's so, I don't know the exact details, but the reimbursement and the setup is so different that it's mind-blowing. So in some way, they're still underpaid, but they're way overpaid than the Rhode Island folks. It's crazy.
Thank you.
Yeah, no, I heard you, and it's terrible. So, thank you.
Hi, I'm Maureen Sullivan, and I'm a spouse here, but I'm also currently a nurse and I was also looking for a new internist since Dave is going to be retiring in 2 years, but everyone's full, so bring somebody back in.
Thank you. Thanks for coming.
Hi, I'm Mike Johnson. Thanks for convening this group. I'm an internist practicing in Rhode Island since the 90s, and I was practicing sort of a traditional care model with Brown medicine for many years. And then in 2018, after many years of discussions like this on a smaller scale, of sort of hand-wringing and talk about being overworked, underpaid, working late, computers on the desk at night, going to conferences where there was always a session on burnout, physician burnout, and then sort of feeling some of those symptoms myself, I decided to go on my own and do a personalized medicine practice that's affiliated with a national organization called MDPIP, so it's a concierge-style practice. And that was in 2018. And so in a way, I'm a symptom of the disease system here, because it's clearly not a solution for the problem we have at the table here, but I think, I was a victim of the trying to practice primary care in a way that was sustainable here. And I think the finances are part of it, but I think really the lifestyle is difficult, and the working the long hours and every night, and not being caught up, being an hour behind, getting flooded with calls. So for me, it was less about, earning a better salary, more about getting some of my life back together again. I still work long hours, it's not easy, but it's very different than, the practice that I had before. And, it's an organization so that allows doctors to spend more time with patients and fewer patients. So, on the one hand, it takes a primary care doc out of the system who might have been seeing 1,500 to 2,000 patients and is now seeing, say, 400 to 600 patients. But on the other hand, it means that it keeps people in the game and happy with what they do. So I go to work every day and I enjoy my day. I feel I practice high quality medicine and I have a feeling of satisfaction. So, it's been helpful in that sense, and I think people tend to stay in practice longer who are enjoying what they're doing. The group that I was working with before, a great group of doctors, I'm still friends with many of them. Increasingly over time, people were spending more time taking on administrative roles or working fewer hours just to get away from the sort of wall-to-wall patients day in and day out. And I think, that's its own problem, is to try to escape from what we all went into this for, which is love of patient care and taking care of patients, and try to do other things just to sort of leaven the load of, the real intensity of primary care. So I'm pleased to be part of this discussion, and thanks for convening this group. When I left to do what I'm doing, it was before, there were real strong advocates like you, and I'm really happy to hear this discussion elevated to this level now, because for a long time there was just a lot of grumbling and complaining about, feeling burned out and wringing our hands and waiting for something to change. So this is the first time, I think, in the 25 years I've been here, that there seems to be a real discussion about, recognizing the problem and trying to do something about it.
Excellent. Good evening. Thank you, Attorney General, for convening us. And I just want to thank everyone around. I see a lot of mentors, a lot of colleagues, a lot of assistants during the COVID pandemic. So I just want to thank everyone here. I work for Open Door Health and Brown University Health, also still serve as a consultant for the health department. I'm an infectious disease physician by training, the only specialty that pays less than primary care. I stopped doing infectious diseases in 2020. It was the last time I did inpatient. I had to give up something during the pandemic, and the inpatient stuff was the first to go. In 2020, also opened Open Door Health with one of my colleagues, Dr. Amy Nunn, she's a PhD, in order to provide safety net services mainly for the LGBTQ community. And that was a gap that we've been seeing in our state. I do believe, and all of us at Open Door Health do believe, that healthcare is a right. We also believe that the primary care crisis is a public health crisis as well, and it ripples all throughout our systems, from the hospitals, to the emergency rooms, to the nursing homes, to everything that we do. And I love primary care. I have found it very fulfilling and exciting. I think it raises some of the questions about how to make it more exciting. But I want to also share, I serve as Chief Medical Officer for Open Door Health. We started it from scratch, including the business plan. We have a multi-million-dollar budget. We bill for everyone that comes through the door. Despite that, we only cover a third of our costs. So we do provide a lot of some care for uninsured folks, but 95% of our clinic population are insured, which kind of mirrors the state average. And despite billing everyone and having a private payer mix above and beyond the public payer mix, we only cover a third of the clinic operating expenses. So some of you may ask, well, how are you covering the rest of it? So another third is 340B. Please defend 340B. We need that, and I'll speak for my other community colleagues at QHC. 340B is so critical, so critical in terms of safety net funding. And then a third of it is grants and projects. And we were the recipient of 2 NIH grant cuts. We lost about $5 or $6 million because our grants have the word LGBTQ in their name. Despite that, we're still in the black. And we still provide care to everyone that walks through the door. So it's been fascinating to make it happen. That was sort of our vision in leaving corporate medicine, was to see if we could have a community-based medicine experience, to see if we could do primary care. I've loved it. Our average age in our clinic is 35, so that's also a little bit rare. We do a lot of sexual health, a lot of STIs, stuff like that. But it's been very fulfilling for me to do primary care. We're leaning into the chronic disease prevention, and just the breadth of primary care as an internist as well is really exciting to treat the whole person, including addressing a lot of disparities. So thank you again for convening us.
Sure, I visited your shop, and it is incredibly impressive. So thank you for that as well, Dr. Ryan.
Attorney General Neronha, thanks very much, as everyone has told us. Thank you for convening this. It's a relief to see somebody, a higher elected official, actually taking a genuine interest in what's going on in the healthcare system in this state and in this country, because it's been pretty much ignored. I've been in internal medicine physicians for the last 41 years, and I currently work for Brown Physicians, which is not Brown Health, so we are not having a problem with United Healthcare right now. So anyway, but we will, I'm sure, at some point. Prior to this, I worked for a few years at Harvard Community Health Plan, which is a staff model HMO that no longer exists in Rhode Island. I've been in private practice for a year, and I've worked at Brown University and also at the University of California in San Francisco. Over the last, I'm also the Rhode Island chair for Physicians for a National Health Program, which is a nationwide organization of over 20,000 physicians who, as the name very unimaginatively states, are trying to advocate for national health insurance. One thing I've noticed, and that we've all noticed, and things that were creeping into our vocabulary are things that we shouldn't really be doing. So I've heard several people talk about risk management. This is something that we're all being told we need to pay attention to. Really, the only risk a physician should be managing is the risk of misdiagnosis or mismanagement. The financial underpinnings of medical care is not our concern, should not be our concern. And all the calls I get every day, doctor, my inhaler is no longer being covered by my insurance. Doctor, the physician you wanted me to see is not in network. Doctor, I can't afford the procedure. I had a guy today who's morbidly obese, has multiple comorbidities, needs Ozempic, he can't afford it. His insurance won't pay for it. So the only useful function that private insurance companies should serve is managing risk. That's all they do. And yet it is the one thing they are trying to avoid doing. As anybody who's been talked about capitation knows. What is capitation? Capitation is a deliberate effort by the insurance industry to transfer the financial risk of care from their own shoulders to those of us and our patients. And we are spending immense amounts of time every night on this electronic medical record, which is now becoming a sort of a contest between us and the people who are reimbursing us for the care we provide to document that we have met quality measures, that we are doing everything that the insurance companies are telling us to do. We're giving lectures to our residents about don't over-order tests, don't over-prescribe, don't order too many consults. Every national study looking at the expenses in the American healthcare system have concluded the exact same thing, which is 1 out of every $3 that the United States puts into its healthcare system is consumed by pharmaceutical pricing and insurance company overhead and paperwork. So a lot of the stuff we do, and the reason why, one of the reasons why nobody wants to go into primary care is that is a lot of what we're doing. Make work created by the insurance industry that we should not even be doing. So a few months ago, I precept the medical residence clinic at the Miriam on Tuesday afternoons. There were 2 other younger physicians who were also precepting, and one of them said, you know what really bothers me as we're all busily typing in between residents presenting cases, you know what really bothers me is how the internet seems to slow down around 11 p.m. And the other 2 of us immediately said, that's exactly right. And then we all looked at each other and realized all 3 of us are spending almost every night to 11 o'clock doing all this documentation. Why? When I took over for Dick Mead's practice, I saw these little scribbled notes on a piece of paper. I knew what was going on. I knew what he'd done for the patient, but it was like a paragraph of scribble, not 4 pages of quality metrics, of review of systems, of 10-point, no offense, Count, but get a specialist notepad. It is 3 pages of boilerplate crap. You have to wade through this stuff to actually get to the meat of the note, because these guys have been reimbursed.
53-year-old man. That's not what they say about me.
Prostate checks.
I know you're not doing it on purpose, but it's again, that is another. I'm getting all these documents every day. Okay, I sent this guy to Kirk Doberstein because he's got spinal stenosis. Page 5. Finally, there's some thinking. Finally, there is some addressing of the actual problem for which I sent this patient to Kirk. And I'm not blaming him.
but his notes are almost unreadable now. Our GI guys, it's just cut and paste, cut and paste, cut and paste, and then finally, oh yeah, here it is, what we actually did this visit. So yeah, reimbursement sucks. And the fact that in part of the country where states are so freaking small, I mean, I could spit from here and I can hit Massachusetts, where there's that much difference in reimbursement over such a small distance is ludicrous. There's no good reason for this. And yet, this is the condition we operate. So yeah, I'm mad, obviously, and we all are, although most of you have been very civil about it, I have to say.
That hopefully will change.
No, I mean, it's given enough time. It's like, I went to a wedding a few years ago, and it was given by my wife's cousin. And she comes over, she's trying to be a good hostess, and she says, "Oh, Bill, you're a doctor." He was a urologist, by the way. And, "Oh, Mark's a doctor too. You guys should talk." And Bill, the urologist, says to her, "You know, Sue, I don't think that's a good idea." And she's like, "Really?" And he leans over to me and he says, "So how's it going?" And I said, "How do you think?" And Sue was like, "Whoa." And that was a few years ago. We might have just started, fist fighting at this point. So anyway, yeah, thank you so much. Because again, this is getting
Martha Wolford thinks she has it tough with me. I'm going to roll you out for our next meeting. She's had a blue as I'm sure you all know.
I can say all this crap to Linda, and then she can actually burden the people in the Senate with it. So,
Senator Jafisa is with us tonight. She is the great spouse of Dr. Ryan.
Oh, I didn't even see you come in.
Champion of healthcare.
I should have known. I felt a disturbance in the force.
Do you like this every night? Doctor.
Hi, I'm Victor Piccolo. I'm Italian, and of course I'm not as emotional.
I'm Irish.
It's a thing now in the States to be emotional. You get it from the top.
Well-directed emotion saved. And I don't think I look like Bernie Sanders, but my career was through medical school and 2 years of residency. Then I've been here for 40 years at Brown. I was director of medical education at Rhode Island Hospital at Brown, supervising 50 programs, 500 residents for 10 years. And then I was not treated properly by Rhode Island Hospital and its leadership. I got a job offer at South Coast, and I was the chairman of surgery at South Coast for 10 years. And somehow, after 5-6 years of that, the South Coast Health System ranked Newsweek something like 80 positions ahead of Rhode Island Hospital. Why? Because it was data-driven. It was outcome-driven. Okay? The Italian health system ranks, Italy, I should say, Italy in terms of longevity is number 7 in the world. You know where the Americans are?
I'm afraid to train.
28. Who spends more money? Who's the country that spends the most money in healthcare? The United States. So it's not outcome driven, it's process driven. The woman they invented, Patrick, was a medical dealer from Wisconsin. But everybody loved it because of the administrative level. And I'm not here to, badmouth the administrators, but they exactly. So I couldn't agree with Mark more. All that mattered was documented. In fact, there were prompts like if you add another system with you can build for a level 5 instead of a level 4. And so, garbage. And finally, the punchline. So I think that maybe a more comprehensive approach to healthcare, including healthy habits, smoking cessation, that is true. And I'm not a primary care, but I mean, those are the things that really affect longevity. And those are the things that, healthy exercise and so on and so forth. So I think Rhode Island has an opportunity to be the leader in this respect, but we have to be outcome driven. We cannot have, complain, and thank you for listening, but we need a plan, we need to enact a plan, and we have to measure the before and after. I did my fair share, I would say, in terms of prevention. I did my videos on YouTube on the value of screening colonoscopies, but why is that Cologuard has the ads? Cologuard does not prevent colon cancer. Colonoscopy does, but it's invasive, so we shouldn't do it. If you add up the cost of how often one does a colonoscopy once every 10 years, it's normal, versus Cologuard, there's no comparison. But so we have to educate also as primary care physicians, patients, and maybe we have to preempt phone calls. We can find a way to communicate, remind them healthy habits. I don't know. I think we need clearly, nobody should be up on 11 o'clock at night working on it. I mean, it's just not healthy for you. So I hope that we together can find a way to really implement changes. But we have to, it has to be patient-centered and it has to be outcome-centered, because we can complain to patients, but the patient is always right? Yeah. We have to be patient-centered. Thank you.
Thank you, Doctor.
Hi, good evening. I'm Martha Cole-White. I'm a maternal fetal medicine specialist and the medical director for labor and delivery at Women and Infants. And I'm also the co-chair for the Pregnancy and Postpartum Death Review Committee. And sort of, here to highlight how the primary care shortage and the primary care crisis really affects maternal health in our state. And really, from reviewing all the maternal deaths in the state of Rhode Island, really the lack of a true medical home for a lot of people contributed to what ultimately led to their death. The majority of our deaths in Rhode Island of people who had been pregnant occur in the postpartum period. And a lot of those deaths could have been alleviated by having a clear medical home for that person. Also, when we think about maternal morbidity, readmissions to women in the hospital, and things that really affect people in pregnancy and postpartum, conditions like hypertension, right, one of the number one problems that people have during pregnancy, or diabetes. And those problems really need long-term primary care follow-up, both in the short and long-term period, if we're really thinking about improving the health of our population and our families. So really sort of highlighting how this primary care shortage really affects our families and the pregnant people in Rhode Island.
Thanks, Doctor.
Hi, everybody. My name is Dottie Lindquist, and I'm really proud to be part of the healthcare team here at the AG's office. I've been here for a little over a year. And I came most immediately from Washington, where I was the chief of staff with the American College of OBGYNs. I've been advocating for healthcare professionals, doctors, and hospitals in Rhode Island for over 20 years. I started in medical malpractice defense here in Rhode Island, and then I went in-house to work in risk management and managing all the suits and claims at Women and Infants. And then I went on to become credentials counsel for the whole system of Care New England. I worked at Landmark during the pandemic with a number of you here. I'm just really proud to know so many of you in so many different ways, and to have stood beside you in so many of the fights that we have been in together. And I'm really proud to, like I said, be here not only for this conversation, but to be part of the Public Protection Bureau, which didn't exist when I graduated from law school, and was looking for my place in the world. So I seem to have finally landed in the right spot with all of you and my team here at the AG's office.
Thank you, Doctor.
As the Attorney General told them, Pat Sullivan, a plastic surgeon. But the reason I'm here is because we finally have an advocate. I've been here for decades, and we've been fighting this battle, which for primary care, but for the specialties as well, has become more and more difficult all the time. The insurance reimbursements, their problems, and just going across the border. It affected my practice, it affects all the practices here, that we could be making a lot more in Massachusetts. That's just not right. But we finally have somebody who cares about that and who is willing to meet with physicians and take the time with meeting with physicians, rather than just with public interest groups and with lobbyists and the people who will pay to come to fundraisers. So I just am really delighted that you all took your precious time to come here tonight, because the kind of things that we're hearing around the table is just what the Attorney General and his team need to hear. We were honored to be here some time ago where I brought that eclectic group of physicians that because I saw so many problems in so many of the specialties, including primary care. So we had pediatricians that couldn't come tonight, but fortunately we have great representation in all of these fields, and I think this is just an extraordinary time to be able to give the information to somebody who is truly an advocate. His team has been very impressive as we've worked with them. And we're just delighted to be here, and thank you for having us.
Sure, thanks, Doctor. And I want to get into the discussion. Thank you so much for your partnership. You know, I saw two doctors today. I saw one who I would describe on the primary care end, and I saw a surgeon. And I like them both. But the primary care, there was a physiatrist, which I put, wouldn't you put that sort of near primary care? I do. No? Well, I'll tell you one thing. He spent about an hour with me. He had no clue who I was, by the way, so it's not like you get special treatment at AG, and sometimes they can't. He spent an hour with me on kind of some tricky issues that I have coming out of some neurosurgery a couple years ago. So we were there for what, like an hour or so? Yeah. And he really listened. And he examined and listened. And then I went to see an orthopedic surgeon, who's great, and he's going to do surgery. That's fine. But he was in and out there in like 10 minutes. Yes. And like when she started asking questions, because I bring her along, because she knows what she's talking about. It was like until he knew she was a doctor, he was not interested. Right? He was on mission, and he was going to get in and out of there. And I've never been to a more efficient, and I've been to a lot now, place to get healthcare than. What is it? Is it University of Orthopedics? Yeah, California, beautiful. Yeah. I want to work there when I'm done here. And I share that with you only because, like, if you're in the system, and I was not in the system much until a couple of years ago, you really do see it. So why are we interested? We're interested because going back to when Roger Williams and Fatima Hospitals were being sold by their parent, I won't give you the whole long story, but they had ruined the company, they weren't able to support our local hospitals. We wanted to understand if they could survive on their own. We looked inside the books and realized, holy crap, they can't. They just can't make it. They just can't, they cannot make it the way things are structured right now. Between payer mix and the way Rhode Island reimbursement rates overall are compared to the United States. Then we thought, well, when we looked at the Brown Care New England merger, we thought, well, you know, maybe these hospitals are in better shape. Not by a lot, and certainly not Care New England. It was like putting two sick dogs together and thinking they're going to get along. Like, nobody gets along when they're sick, right? They're just as sick as a lot of Rhode Islanders. So we rejected that for a whole host of reasons, but we came out of it thinking, as I mentioned earlier, you know, I saw a cartoon that said they wanted to get married, and Charlie Hall did a cartoon that said, does anybody object? It was like a wedding thing, and here's Neronha, no. And I thought, that's not how I want to be remembered when it comes to healthcare. You know, as the guy who always says no and then lets everybody else go out and try to fix it. So at that table right over there, this whole team, and not all of them were here yet, but some of them were. I don't know where Kate Sabatini went, maybe home to put her son to bed. God, she's got good judgment. She leads our civil division. Adi was here. I don't know if Sarah was here, but I challenged them to come up with like some proposed fixes. And we didn't know, like, I didn't know if we could do it. I didn't even know we could come up with a decent proposal or part of a proposal. And to their credit, and Julia was here, I think, at the time for sure, they went off and they started to come up with some ideas, and they didn't do it in a vacuum. They knew they had to go out and talk to people. So what we're hoping to do is, in the next 18 months or so, continue to roll out things that we think will make things better. And not spend time on things that won't. Like, I agree, maybe it didn't come out clearly, but I think it did actually. I think another med school in Rhode Island would be just fine. I'm agnostic about it. If they can do it, great. Why not? More doctors? Sure, great. That's not going to solve our problem. Not for a decade. And there's no guarantee they're going to stay here. And even then, right? There's no guarantee they're going to stay here. So that's not going to solve the problem. So I don't want to waste time. And some people get upset with me when I say it this way. And I don't mean to offend anyone, because I know that I do when I say it that way. But that's not our solution. We need real solutions now that will stabilize this problem. Now, it's not acceptable for Anchor, which was a perfectly well-run practice from everything I could tell, to wind down and leave 25,000 patients in the wood. I don't blame them, and it's wrong for others to blame them, frankly. It's not their fault. It's the structure of how we do medicine here. It's when Shelley first got here and she could practice with 2 other doctors, it's inconceivable to practice that way, except for Brendan and a few others out there, right? I mean, but really, 3 doctors, it sounds quaint today, and so then comes Coastal, and then comes Brown, and I don't think it's necessarily, I'm pretty confident, it's not ideal to have our primary care internists, pediatricians, if you want to break them up, doctor, so we don't miss anybody. I'm sure I'm missing others, and that includes advanced practitioners too. I don't think it's great for them to be in these huge systems for all kinds of reasons, conflicts of interest among them. So in a perfect world, we would detach them. It's been really hard to bring the private insurers to heel, in part because there are so many self-insureds here. So that's part of the problem we have. So many Rhode Islanders are self-insured or self-insured through entities that self-insure, like the state. So Blue Cross may be managing it. And we don't have a lot of direct jurisdiction over them. We really don't have any, although we try to leverage, for example, network adequacy, because I believe that if you sell insurance, you ought to have to provide enough doctors to service the people to whom you have sold insurance. So Martha Wolford and I have had some go-rounds. I've said to her, look, maybe if you can't put more money in the pool, divide it differently. Treat primary care, internal medicine, pediatrics, with the importance we give it. I describe it as the air traffic controller of our healthcare system. That's really what you're doing. You're managing all these things in here, right? While, and if you don't get that right, there's chaos. So I share those thoughts with you because I hope that gives you some appreciation as to why we're paying attention. It's not just because I have loved ones who are in healthcare, it's because that's part of our job here, to regulate big transactions. But having regulated several of them now, we saw the problem. And I don't know, I don't know how we get out of this. I know money's a big part of it. And the last thing I'll say is before, I would encourage others to do a Mark Ryan here to get us rolling. I think one of the problems we have as a state, from a government point of view, is that we budget healthcare as an afterthought. So we don't think of healthcare. So why all this struggle to raise Medicaid rates to Medicare? It's $3,700, $200. You know what I mean? $200 commercial, $100 Medicare, $37 for an imaginary examination. But that's the relative reimbursement. Why is it so hard to go from 37 to 100? It's so hard because we start thinking about spending more on healthcare when we get to the end of the budget cycle, right? But wait a minute, all we've got is what we can find under the seat cushions. And where are we going to find the money? Well, if you start with healthcare at the beginning, along with other important things, then you don't have to, you're looking under the cushions at the end, because all of us do that in our own budgets, right? You decide whether, whatever, you can go out to dinner this month again, or you can afford new skis for the kids or whatever, but you put food on the table first. You make sure there's a roof over their heads first. And you make sure you can get to work and they can get to school first. To me, healthcare belongs in that subset of things that are first. And our government thinks about it too much as last. It's the skis to them and not the food. We've got to change that thinking. So I have a couple of goals. One is that it not end tonight for sure. To me, there's a whole bunch of little things. Dr. Lamp, you brought up some when we met the last time. Shelley's brought up things about prior authorizations and why do I need a prior authorization for a test in my office when in the ER I don't. And you're telling me to keep my patients out of the ER, but I need a test and I need a prior authorization where if they go there right now, they can get the test right away that they need, maybe stay alive. Heard that one a lot. So some of them are small fixes, but important fixes that go to lifestyle and patient care and frustration. And others are more fundamental, like revenue and payment how do we get kids to stay? I mean, I have a son who's doing an internal medicine residency right now. Whether he'll decide to do internal medicine, I don't know, and if he does it, will he come back this way? Who knows? But I think he thinks about those things. I'm gonna stop there, and I'm gonna open it up to anyone who wants to elaborate on anything anyone said, or has any big or small ideas about ways we can make this better. I will tell you that we do two things here. We propose real things. We sue bad people like PBS. We propose real things and try to get them across the finish line using our legislative team, which is excellent. We propose other ideas and use the bully pulpit. I will tell you that I talk about healthcare every public speaking chance I get. Whenever I speak to Rhode Island, I speak about healthcare. If I'm at an elder abuse summit, I talk about our healthcare system as a form of elder abuse, because it is. Having an older Rhode Islander sit around in a ER 5-10 hours is effectively abusing them, not at the hands of doctors, but at the hands of government for failing them. Now, let me just say this about kids' dental care. The fact that 25% of our children in the Providence school system have serious abscesses in their teeth, and no one's done a thing about it, is another example of government failure. And so the notion that dentists don't take, and I have a lot of friends who are dentists, we're trying to partner with them on a bunch of stuff. I love my dentist. He's a Navy veteran, by the way. And I love that about him too. But they don't take Medicaid. And we got 40% of our kids are on Medicaid. Like, they're the ones who lose. People like me don't lose. I'll find a doctor to the day they put me in the ground. But people on Medicaid lose. And lots of other people of economic means lose, of low economic means too. And this really is my last thing. Here's the last thing I want to say. What really offends me is when people say that Medicaid people don't work. People on Medicaid don't work. They work, okay? I heard a senior government official say that people on Medicaid don't work. Well, if the feds cut Medicaid, they're gonna have to work. Like, you know, they're your patients, they're working. So we chose as a people, as a government, as a state to insure those people. It's time to pay the people who actually provide the service, right? Like anything else, you wanna insure them, you gotta pay for it. It's the right choice, let's do the right thing. All right, now I'm done riffing. Now, you go riff. It's okay to get angry and express yourself. I think doctors are flattened up. Let it out. This is your chance. Oh, go ahead.
Thank you, General. I was going to go last, but I'll lose my train of thought. Just three brief things. First, really to tie Dr. Ryan's comments together with yours. I was going to bring a slide, but Lee promised me he'd hit me over the head. But just,
where's your PowerPoint?
Yeah, exactly. Just
I can see that.
This pie, okay, with the little sliver for primary care, and I might be a percent off one way or the other, but say it's 6 or 7% of the total healthcare spend, which, by the way, is about half of the administrative costs of any payer out there. And then into that sliver of the pie, we're going to put prior authorization responsibilities. We're going to put referral responsibilities and EHR and all that comes with the nonsense of the EHR and et cetera. And then most recently, back to Dr. Ryan's point, we're going to make that sliver of the medical population a health insurance. So with these full risk models that are being proposed as a solution, and our group is becoming involved in it, the insurer is going to develop products and market them to employers throughout the state without any input from the risk-assuming physicians. They will keep 12, 13, 14% of that revenue and put the entirety of the rest of the revenue into that sliver of doctors to manage the healthcare needs of everybody else in the pie. What could possibly go wrong? And they do this when the doctors who are in that 7% of the pie are evaporating. We're just completely evaporating. So what could possibly go wrong with that? The other, if I may, and I did have the privilege of my staff put together a little brief PowerPoint for for Lee and Dorothea and Jordan. And this is kind of an ask, but you've done such remarkable things with prior authorization in such a short period of time. Very close to that is the referral process. And I'm very interested to hear from my primary care doctors around the table, but our practice looked at it, and it came to light with a recent shift in Blue Cross plans, where apparently the elimination of the individual HealthMate PPO Medicare Advantage plan replaced by Blue Chip for Medicare Access. Ends up where they all now need referrals to other doctors. So my staff informs me that 80% of our patient population is part of the BCBS membership. There are 13 Blue Cross plans, and 8 of them require insurance referrals. We broke it out. To do that, we do 125 to 150 referrals a week. We do almost 8,000 annually to meet the demands of the referral requirements. And we have patients who happened to me today on the way out the door. I need these referrals for all these doctors for the year. One of them is out, one of them is out. That's a lot of work. Every single one of those referrals that come into our office, every 8,000 of them gets approved and sent. Every one of them.
Right, they never deny.
Now, I know in the day, and with the doctors who have been around as long as I have and longer, it was meant for us to serve the gatekeeper role, for us to say, okay, I realize you have a little bit of chest discomfort. Why don't you come in here? Let me do an EKG. Let's see. We might be able to avoid that referral. That ship has sailed. We have zero capacity, at least in our office, and I'd like to hear from my colleagues. We have zero capacity to meaningfully triage that thought, get them in, do something to mitigate the referral and save this healthcare system money, and the system's not treating us very well.
Why do we have capacity?
So I think it was best described. I think it was either Dorothea or Jordan had said this is a vestige of a leftover something. It's a complete expense. It's nothing but busy work for us and a distraction for us. And at least in our practice, it's a $53,000 a year expense for us. So that is an ask of you to follow through. And I know Dorothy and Lee and their team are seriously looking at this. But that would be a very big help. And I think I'd be surprised if my colleagues disagree with me. And then one final comment. I was leaving your Boston Globe interview roundtable, so forth, and there was a couple in the elevator, and they asked, "Did you go to the Globe?" I said, "Yeah, I did." And he said to me, "What's the answer?" And I said, I didn't know where this came from. I said, "Take an eraser and erase the border of Rhode Island and make this a regional market." And it was just in the spur of the moment. So I just offer you that. I think our market's too small, too constricted, too sick, too elderly, so forth, for the market dynamics of this to work. So those are my 3.
Well, it's an interesting observation, the last one, because it certainly would adjust for this disparity between Connecticut, Massachusetts, and Rhode Island for certain. And I mentioned earlier at the top about how legal principles, like the market, such as it is, it's not a true market, is outpacing the law. Because when we looked at the merger, we were looking at a market that was Rhode Island, just around the border, and my antitrust team, continues to believe that that's the market. I don't know that that's really the market, or if it's the market for purposes of antitrust, it shouldn't be the market for purposes of reimbursement. And I haven't been able to jive those 2 things. But I think that what I've heard consistently, and I don't think it can be seriously disputed, and I don't think it needs further study, is that commercial rates are higher in Massachusetts. Medicare is higher in Massachusetts, harder fix for us because it's a federal thing. And Medicaid is higher in Massachusetts. And so it's no shock that when, if you want to go to you can go to Westport and Newport, and you're going to make 30% more in Westport, Massachusetts, you're going to go to Westport. When you're starting your next chapter. You can be the internist doctor that you so eloquently described, But you can just do it and pay your law school loans, nowhere near as high. You can pay your med school loans off much faster.
There's that one son. There's that one child.
Yeah. Yes, that helps. I have yet to. All right, anyone else? Yes?
Well, I mean, to dovetail what I think everybody has said, we do so much stuff that has absolutely no benefit to the patients. And we even, it's like 1984 with the Newspeak. Quality measures. It's got nothing to do with quality.
No.
It's all performative. So for example, when we come in, we have to ask our patients about their housing. Now, if they have a housing problem, there's absolutely nothing we can do about it. However, we then have to ask them all about how depressed they are, and if they really have a need for a psychiatrist, we can't give them anybody. But then most importantly, we have to ask them about food stability, which is very important, except there is absolutely nothing that we can do about this. So instead of going back to the, so again, in the Mesozoic, we were internists. You didn't hear the term primary care. It kind of sneaked up, and it became the dumping ground for a lot of stuff. So for example, I remember when we started to have to get prior authorizations for high-end imaging. And I remember having discussions, this was 20 years ago, with the insurer saying, look, I've done 100 of these. Everyone's been approved. All it's done is taken up 115 hours of mine to do it. At what point exactly are you going to give me the benefit of the doubt? And I had an honest answer for somebody at a nameless insurance company, and the answer was never. And when you read about this in medical journals, it's been written up in the New England Journal, it's been in the Annals of Internal Medicine, none of these impediments do anything to benefit the patients. It's simply putting up barriers so that doctors who are not that committed to taking care of their patients don't order this stuff. Now, how that actually benefits insurance companies, I don't understand that. But it is,
It lends credence to the narrative that it is our activities that are driving the out-of-control costs in our healthcare system. As long as they make us do all these quality measures, these prior authorizations, all these other things, it maintains the fiction that it is what we do that's driving costs up. Whereas every national study, as I mentioned earlier, has shown that the vast majority of cost drivers in our system are actually pharmaceutical company pricing and insurance company overhead.
Absolutely.
But in order to, it's sort of like the Wizard of Oz, where Toto has just pulled away the curtain, and you see the wizard there manipulating his machines. Pay no attention to the man behind the curtain. So that's why we're doing all this form filling out, to maintain the illusion that somehow we have to rein ourselves in, which is nonsense. That is not what the problem is.
So in terms of reinventing the wheel, does anybody here remember the Chronic Care Sustainability Initiative? Okay, so this was like 20 years ago when Chris Kohler was the insurance commissioner, and he was able to do something genuinely excellent. And I'm not a lawyer, my son is, but somehow he was able to get all the insurance companies together to run a pilot program for sustainable primary care. And it worked great. And I mean that by we actually were able to hire some more doctors. We actually were able to support staff to do some of the things that we're talking about. My particular practice graduated out of this, and things happened, but I don't know what became of it. I can see that he's no longer the insurance commissioner. I don't know who the insurance commissioner is now, but the point is, this is something that happened that was quite successful temporarily, and instead of going out to reinvent something, perhaps we might want to take a look at what became of that program and why it didn't continue.
Hey, my impression, perhaps not entirely fair, because I don't really never really understood, my team probably does, but I've never really understood exactly what the health insurance commissioner is doing or trying to do. Every year the insurance companies come in, they ask for more. Every year. And we always object. They don't listen to our objection. The insurance commissioner may cut it in half When you're asking for like 15%, you cut it in half to 8%, that's pretty good, right? But where does the money, I've never understood where the money's going. And that's always been my concern about that. We're about to go into another round this summer. So the OHIC has always been a bit of a mystery to us, and that's why we have, among the things that we rolled out a couple of weeks ago was the concept. There's more meat on the bone internally that we haven't shared yet because we want to really make sure we get this right for reasons which I think will be apparent, is to pull, the last thing we need is more bureaucracy. I'll be the first to acknowledge it. That said, what we don't do very well in the state is healthcare thinking and strategic thinking. It's why we're doing some of it here, but really in a perfect world, it wouldn't live here. It would live at RIDO or OHIC or some other thing like Massachusetts has. It gets data and crunches it and then turns it into something that legislators will, or governors will actually listen to. And so one of the things that we're going to propose in the fall is just that. Something, not an additional thing, a reinvented thing. I told you.
So I'll comment on that because as you know, working a lot with the director of Medicaid and working with OHIC a lot, I think they have to say a lot of good things. I think they are educated. They're Chris Kohler disciples, you know, and they're all in the same. They work in the same avenues. They have the same vocabulary, and they say most of them, mostly our allies. So they're some of our biggest allies. They're just not listening to them. Nobody listens to them. The insurance the insurance companies tell them to fuck off, basically. I mean, that's what and then what? You know, so this comes back. It's not a medical thing. It's not a data thing. They did the data. They know that you do this. They did this. Talk to the Corey King, who's the Health Insurance Commission. They just did a study where if you build the same codes in Rhode Island and you bill them in Massachusetts, there's a 28% higher payment. And that's something else that, you know, all these pet peeves. I'll bring up another pet peeve. People say reimbursement. It's like solutions. When computer people are talking about their coding and their solution, these are what kind of terms are these things? There's no one's getting reimbursed. Who's been reimbursed for their services? Who's being reimbursed? I'm not a young doctor. I've never been reimbursed. So please don't say reimbursed.
You want to say paid?
Paid. Yes, we're going to get paid like anybody else, right? So who cares about how we get paid? You know, it's that we get paid. You know, so just pay us. You know, let us do our job and pay us. Get out of the way, insurance companies. Government, help us. Lawyers, help us.
Sure.
You know, that would be nice. You know, and I don't get it, but there's history that's in the way. So why we pay so crappy in Rhode Island? To my experience and thought and looking and hunting and pecking with these unbelievably horrible people that are in these insurance companies. It is historical. You know, it's all about history. It's about how they took advantage of doctors in different areas, and our doctors just happen to get more taken advantage of. And because they get paid more, they did. There's no law that says we have to get paid less. You know, we just got paid less. There's no law that says there only has to be 2 health insurance or 1 health insurance. There just are, and they run the show. The governor doesn't run that show. You know, no one. They decide how much I get paid. I don't like it. You don't get to be a doctor here. You know.
Would you take Medicaid?
Yes.
The government decides how much you get paid.
Yeah, Medicaid is also an interesting thing. So Medicaid, no. so the government, meaning the state, decides.
Yes.
Right. So.
They decide you're worth $37 as opposed.
Well, they gratefully for a good discussion with pediatricians, they increased it to 100%. The problem is that
that was our legislation.
Yeah, well, Medicare 100% is the internists around here can tell me. Medicare 100% is good pay, okay pay, or crappy pay. Crappy pay, right? So 100% of Medicare is crappy pay.
And do you know what's going to happen before that? Zero. You're getting nothing. So when I come back to the Medicaid office, let me just share this with you. The Medicaid office does nothing to leverage the Medicaid office, okay? The Medicaid office, in my view, is weak. I think they could be much stronger. Talk about the Office of the Health Insurance Commissioner. They're raising rates on payers 8% a year. Where's that money going? Do you know? I don't know where it's going. Exactly.
No,
That's my point. But it's the government that's paying you your Medicaid. And so the problem is that government doesn't appreciate that Medicaid is how you get paid for healthcare.
Yeah.
Right? Well, hold on a minute, because that's 40% of Rhode Islanders that get paid.
I'm a pediatrician, so it's
Right.
50%.
Well, fine, but I just want to finish my point, Doctor, if I can.
Yeah.
Because to minimize how you get paid as part of state government is exactly why we're in this crisis, in large part. It's why dentists don't take Medicaid. Medicaid is a huge problem here, and I don't want that to get lost in our discussion.
I mean, right, 100%. Look, again, as a pediatrician, like it's a big deal, but I also don't view it as the solution. It's not the solution to the problems. The main driver, and where everything, we're 2 tiers, so depending on how you want our federal government to handle things, but it is the people who run the show are the commercials. They set the rules, and Medicaid sort of follows along. They don't run the show. So yeah, they should pay us. Both should pay us accordingly.
We are in total alignment. But listen, I am no friend of Blue Cross. If Martha Wolford was here, she would try to hang me, from one of these lights. But I will say that, but for commercial, we'd be even in worse shape.
100%. Yeah. No, 100%. And right.
And from their perspective, you know what they say? Because we didn't have to rule with us. They say, well, okay, what about Rhode Island Medicaid? And my answer is, well, what about Rhode Island commercial? Right? But we've got to raise, in my view, our view, we've got to raise all three. You got to raise Medicare, you got to raise Medicaid, you got to raise commercial. But I got to say, moving that rock is very, very difficult in this government that we have that doesn't view healthcare, let alone as a universal. Maybe they may view it as a universal right, but they're not ready to pay you for it.
That's right. That's right.
And that's the problem.
And I don't know how to change that.
Well, I do.
All right.
You guys got to speak up, and we got to work together. And we've got, listen, there's nothing that prevents you, I think. I've talked to a lot of doctors, and how do I put this? And you know that I think the world of you. I do. You're naive in how you think power is flexed here. You can hire the best lobbyist in the world, but if that's not a lobbyist that has the speaker's ear, forget about the governor. The governor can put any budget he wants out there. The speaker's going to change it. If you don't have his ear, change will not happen. And so doctors have to figure out a way to break through that, and providers, as I see you nodding your head there, my friend. Providers have to break through people who aren't ready to listen to you.
Okay, well, so now we have to be lobbyists and figure out how, the intricacies of Rhode Island politics as well. I mean,
Yes.
and it's just like, how much responsibility are you going to put on the doctors? We need to do this together.
I agree.
And we need people within the government to say, this is a problem, this is the power I represent, and this is the solution how I'm going to help. Because I don't think it's rocket science. I think what you just said is correct. All three have to pay more.
Yeah, no, I agree.
So that's it. Done. We can all get up and leave and get more.
We don't control Medicare. That's a big problem.
Well, right. So that's a problem. Not
so much for you.
Not so much for me. Right. So I'll bow out of that a little bit. But it does set the RVUs. We still follow along some of these issues, even though it doesn't affect us at all, and because of history, we follow CMS issues. But the point is that who's going to help us? That's the point. I think. We can all tell you what the then okay. Then let's enact those things. And like you're saying, well, Medicaid doesn't leverage the Medicaid said, all right, we're gonna pay pediatricians 100% Medicare. They already did that. They did that 2 years ago.
Yes.
It's because we made noise.
It's great.
And said, okay, the kids aren't gonna get served. Kids aren't gonna get what they need. Do you wanna not take care of the children in the state? Or do you want to? And you have to pay for this. And that truth hasn't changed.
Can I make a comment?
Yeah, sure.
So following up what John Gaines said, with respect, I think the public is to be protected. They perceive us doctors as wealthy. So my point is, for example, as John was saying, if I had to order a CAT scan for a patient that had cancer, pretty serious, right? I would get a call from the insurer saying, no, you have to get an x-ray first. We are not approving the CAT scan. Now, the National Cancer Center Network guidelines, pretty reputable, that accredited cancer center says the CAT scan is the modality. But I have to be on the phone with a nice person that said, oh, I understand that, but you still have the, if you order the x-ray first, and that doesn't answer the question, then you can order the CAT scan. So I do that. Is that efficient? No. Is that in the best interest of the patient? If it was the radiologist between us, no, but it has to be quality driven. Okay, we have to prove that not just paying us more, but letting us adhere to standards of care that have worked in other countries that have a longer life expectancy and health. So can we talk about quality of care? Because the public is not going to have sympathy for you, for God to say, I don't know.
I know you're right in the sense that, you were absolutely right, Dr. I think in many ways. I think that, though, that if you don't fix the money part of it, you won't fix the inside game, which is making doctors happier in their profession here and attracting them here. That's what worries me.
I was respectfully suggesting we tie them together.
Yeah, no, outcomes, I love outcomes. And I actually, if I was gonna vote, if you're gonna give me a vote to how to actually have a healthcare system in the country, which I would argue we don't have as a healthcare system.
Right.
I would say Germany or France, with respect to Italy. Germany or France. Why? Because they have the best outcomes, okay? So they have the best outcomes. Let's do something that they're doing. Nobody talks about that, at least as far as I hear, I read, I'm on all these different committees of the AAP and whatever. It's either Medicaid for all or this nonsense, commercial, profit-driven nonsense, So why do that? Why don't we look at what is actually working in other countries?
Exactly.
And you go to the Commonwealth website and they compare this. You guys are aware of these things, right? I mean, it's a nice 3-page summary. Anyone with basic education could read these things and say, this is what we should have. So
go ahead.
Well, it's like asking, can we go metric? Every other country has gone metric. We can go metric. But the reason we have the system is because a small amount of people, relatively speaking, are making so much money off it, and it's got nothing to do with actually taking care of patients. Ozempic costs $4.94 a month to manufacture. $4.94. I have this conversation, believe it or not, 30 times a day. In a loser country like Europe, it's $88. Here it's $1,350. It comes out of the same machine. This is not going to get better under the current administration. But, it is, who's making all that money? The pharmaceutical companies
who's stopping it from
who are
changing to
only,
something else.
so we hear about how important it is to negotiate prices, except Medicare, which is the biggest consumer of pharmaceuticals in the world, hasn't been able to do that negotiation, which is ridiculous. So who benefits from that?
Well, that's why we
companies,
sue
insurance
the
companies,
pharmacy
for-profit.
benefit managers, because they're the ones
And
that have that
they
delta,
too.
and we're trying to eliminate that They're the ones who've driven those costs of drugs up.
So every
And by the
major
way,
study
everybody's on them.
shows.
Have you seen all these people that you run into and all of a sudden they've lost like 30, 40 pounds? It's like,
So we know.
if you did it the real way, like, you lose credit because everyone just assumes you're on the drugs. But that's why we sued those PBMs for exactly that reason.
You
Because
sue
that
bad
became one of the
people,
things
General,
that
like, you go right ahead.
That
But what
margin
I'm-
are the pharmacy benefit managers.
And to that-
And are supposed to negotiate drug prices down, but don't, they raise them.
Correct. Well, they have profits, but every major study, and again, this is like, can we go metric, shows that the greater percentage of internal medicine, pediatricians, family practitioners in an area, irrespective of the country, the lower the overall cost is. Because everybody, you don't go to an office, which is a traffic cop. Oh, you have chest pain, you need a cardiac. No, you don't. Oh, you had diarrhea. Well, obviously you need a colonoscopy. No, you don't. So there are very good statistics that show that 26% of all orthopedic procedures that go forward every day in this country that are approved by Medicare, we know don't work. So it's just evidence-based medicine has not been disproven. It just hasn't necessarily been proven profitable to the people who have been gaming the system.
So if I may very, very quickly, Prophet, and bravo to you for the PBMs and to Dr. Chan, the double-edged sword of the 340B. So as this goes, I text my friend in Washington, D.C., who's very, very high in pharma. University of Vermont buys a year of Remicade at 340B price for $8,500 and bills Vermont Blue Cross $95,000. So there are benefactors to that.
Yeah, so I think when we talk about 340B, we need to consider primary care and community clinics versus hospitals. Because I think the community clinics are what 340B was made for initially. And I think there's data and there's articles that have shown that the hospitals, it helps fund the hospitals, but it's not necessarily used for its primary intended purposes. So as we talk about 340B, I would really strongly advocate to make sure that it protects primary care. I do want to ask one question for the group. This may be a little bit controversial. I know this has been floated around. But when we talk about the funding and the reimbursement issues, I know that it's been floated around increasing taxes potentially taxing some unhealthy behaviors to fund healthcare, things like tobacco, marijuana,
Sugary drinks.
Absolutely.
I guess just from your perspective, I'm curious about the team here, the feasibility of that. Obviously, whenever the T word is mentioned, it's, turns a lot of people off, but especially if the federal government doesn't come through with Medicaid or have Medicaid, we're going to have to come up with more revenue at the end of the day.
No question. I think those things are all on the table. I called Keith one day. The team really, they suffer at my home. But I pushed them to get this announcement out before the end of the legislative session so that we could, I kind of saw that the big hospital bill was not going to make it, or I thought it would make it. So I wanted to get at least our primary care bill out, which would raise those Medicaid and Medicare a step. So I pushed them to get the PBM complaint done so we could do it at once. Because if you do things piecemeal, I've learned over 20 years of leading offices, nobody pays attention. If you land it all at once, they'll may actually listen to you. So to make a long story short, I realized that the first question we're going to get, where are you going to find, conservatively, I asked Lee, what's it going to cost the state to pay from Medicaid to Medicare? $50 million was what I heard, conservatively. So I knew the first question, and it turned out to be the first question. Where's it coming from? So I called Keith, and I said, Keith, find me 50. Was it 100 million? I told you.
You asked for 100.
Yeah, go through the state budget and find me $100 million. This is on a Saturday. I'm sorry, Rachel. You're used to it by now. So anyway, to make a long story short, Keith came back, and we actually had some ways. But one thing the legislature doesn't like is me telling them what to do. So I didn't want to say, well, take it from here, or take it from there, or take it from there. But among the things that we looked at, there was some capital funding around were those very things, sugary drinks. What were the others, Keith, that you found?
New provider taxes, like on ambulances, ambulance companies.
Not the ones for emergency, the
correct, yeah.
Transporting.
Yep. There's a way that you can do it in a pretty reasonable way that a lot of states have put in place. You can put kind of like sin taxes on things that drive up healthcare costs. Certainly, you can There are many other ways to increase taxes in kind of a fair way. But for the amount of money that we were really looking for, you actually didn't even need to do those things to kind of like right this ship. It was more just like removing money from like less, frankly, acute issues to a crisis that we're facing.
Yeah, so we have thought about it, and I think if we get to that point, those are things that I would support. But it goes back to what I talked about earlier. Healthcare, you have to pay for healthcare. We've decided to insure all Rhode Islanders. If the federal government won't pay their share, we're gonna have to come up with more money. If that means raising taxes, that's what it means.
One of the crazy things about this is that if you look at national estimates of how we're budgeting healthcare and where the money's going, we already spend enough money to provide complete medical and dental care to every American. We already spend that much. The American healthcare system, we are spending 2 to 3 times what any European country does per capita on healthcare. So if we wanted to, and eliminated all the waste and inefficiency that comes from insurance and pharmaceutical companies, we could have all of this stuff without raising taxes at all, because we're already paying for it, we're just not getting it.
Well, you cut off all the profit to United.
Well, to all the insurance companies, because we really don't need
I
them.
understand.
And if you look at
That's
Germany
not
and
gonna
Switzerland and Holland, they do have good outcomes. Not that much better, by the way, than Norway and France and Italy. But they also spend more per capita than any other European country because they allow private insurance companies to operate within their borders. And I think one difference between those countries and the United States, no offense to our government, is that our politics is tremendously sensitive to money, to what Anthony Scalia would call free speech, and the rest of us call bribery. So allowing large multi-billion-dollar companies to have a vested interest in how healthcare money is spent is inherently unsafe in this country. So I would argue, as do some other people, that a single-payer system would really fix all of this. Doing it on a state level would be difficult because a lot of the savings that you would get from the single-payer system have to do with the amount of money that hospitals and clinics have to bill. They have to spend to bill insurance companies, whereas if you have just one insurance company, it's a lot cheaper. To give you an example, Massachusetts General Hospital has more people in their billing department than they have beds in the hospital, over 300 people. Toronto General in Canada, that's roughly the same size, roughly the same number of people served, has 3 people in its billing department. So the amount of money that we are wasting on having to deal with the private insurance system is not justifiable. It detracts from healthcare. We have 2 things in the United States that don't occur in any other industrialized country. People go bankrupt because of medical costs in this country. They do not do that in any European country, in Australia and Japan. And 30,000 Americans at least are going to die this year because they don't have access to healthcare because it's too expensive. That doesn't happen in any European country. And these are the direct consequences of having a private insurance system. So Germany and Netherlands are definitely better, but I don't think their system will work in this country because when you have a private company that generates that much profit, it becomes politically very popular.
You can regulate the crap out of it.
Well, you would, but we've tried that, and yet they find really good ways to get around regulation.
Doctors, can I come to Dr. Harrop, who has been patient?
So I've got single payer, all for it. Sin taxes, love them. I spent 30 years trying to get people to quit smoking, but as soon as it hit $10 a pack, a lot more did than whatever I did. So, absolutely. Every time they raised taxes on cigarettes, more people quit. And it was, but I kind of like to bring it a little bit more back to Rhode Island, but although I agree with everything you said. So obviously, yes, we have to try to, the cross-border, we have to try to equal what we're getting in Massachusetts and Connecticut and everything else. But there's some other things. So one of the things that they're doing now is payment for medical school. So I had 2 Rhode Island hospital residents who I could have definitely hired. They really wanted to come work for me. I could match the salary, but they went to the VA. Why? Because the VA would give them $40,000 per year for their medical school loans. Now for that, so they do that for 3 years, they get $120,000. Then they had to stay 3 more years. But I couldn't do that. So I think, the medical school loan thing is really big, and we really need to push that. And, when the other thing that, when I went to the University of Vermont, and back then, the UVM, Rhode Island paid the state UVM to, I don't know what they gave them to say 8 spots for Rhode Island. But we had to come back here and work for 7 years. Now, once you're in a place for 7 years, you're pretty much not going to leave. When you're that age, you're like 32, 33. So that would be another. I mean, that's getting people to come back. So they get out of residency. They're like 28, 29. You get them here for another 5 or 6 years, they're probably not going to leave. So rather than build a big medical school, we could maybe carry on.
I was going to ask whether you collectively thought residency was more important than medical school.
Absolutely.
So expanding
100%.
Residency slots here would be more important.
Well, if the residency would take more Rhode Islanders, never mind the medical school, because then they go to medical school and then they go to Chicago and they stay there. The resident, almost everybody I've hired in the last 10 years have come out of a residency program here, and they've stayed, and they weren't all native Rhode Islanders. So the residency programs are far more important because they're at an age where they're just not going to move around.
And that's not a theory. So this was done in Florida. So Florida needed more doctors. They opened more residency slots. They got more doctors.
And who controls number of residency slots? Is that a function of RIDO? The systems themselves? Or is it
It's a residency review committee that geographically will look at it. It's federal dollars that come in. What's that? It's kind of your money.
Because they have some
Eventually,
they're having direct of it is, for example, for surgery, you have to prove that you have enough volume of certain operations, complexity, and then you can apply for an additional residence. The residency committee, the Accreditation Council for Graduate Medical Education, you have to petition them and prove that you have the volume.
But Dr. Lamp did it.
Not necessarily the quantity, but the volume.
The other thing is, I just want to put in a plug for private practice. A lot of us don't want to work for big corporations. We don't want to work for New England. We don't want to work for Brown University Health. We have private practices. We think we do very well. We practice a little bit different kind of medicine. We're a little more autonomous, the people in my group, and they come and they stay because I let them kind of do what they want. They don't have to fit into a box. So, but, I can't, like the VA, pay an extra $40,000. I can't, I think that was your tour, you said John Fernandez says he loses $150,000 on every primary care doctor. I can't do that. I pay my bills, I pay them well, but I don't need all this other stuff. So, but what those places can do, what I can't do, is hire someone that needs a visa. So Coastal, Brown University Health, BPI, because they're nonprofit, can hire people with visas. I can't. And there are a lot of good doctors out there who would stay and come if we could get them visas. And I don't know how much pull anybody in the state government has about that.
Well, these are some of the practicalities you were talking about with the speaker and having the speakers here who would like to meet with this group. He told me he'd like to meet with this group. So let's get the speaker involved in this, you're involved in this, and I think that we can make some big changes with the ideas around this. I think that's how to move it forward.
I totally agree. The speaker is very well-meaning. He doesn't have a primary care doctor. He wants to do the right thing. So he would really love to come for that reason alone. He's a good friend of Dr. Sullivan, as he is of mine. I think it would be very helpful for him to hear from you, because at the end of the day, it's the speaker who moves the money needle, at least when it comes to state money. Federal money's harder, commercials are hard enough. We haven't quite figured that one out yet. Yes, Doctor.
I think one of the things, just to piggyback on what everybody's saying, you talked a lot about logistics and reimbursements and all of that, or payments, sorry, and that. But we're in a crisis now. A lot of that through legislation and moving the needle is going to take some time. So we kind of have to figure out a way to recruit people now. Because I get calls on my phone, and like I said, I have a small practice in nursing homes, but I probably get 15 calls a day. Hey, are you accepting new patients? Hey, are you accepting new patients? I found your number somewhere on the internet. So we have to figure out a way to make it, to kind of make primary care great again, I guess, if you want to say. Right? You have to make the state of Rhode Island attractive. And how do you do that? Every single one of these fellows or internists that I probably interview, I don't know, maybe 7 or 10 of them a day. All their questions are how much money am I making? How much time am I getting off? And how many holidays do you observe? How many administrative tasks do I have to do? What's your ancillary staff that does the stuff that I don't want to do? What's that infrastructure look like, right? So I don't know that we could solve all those issues, but low-hanging fruit is a term I like to use. Tax incentives for new docs coming in to open up a primary care practice could be something. Public student loan forgiveness program that was through the federal government, which we don't know will stick around too much longer. Maybe Rhode Island develops its own. For certain folks that are coming in. And we have to come up with a creative way to get people now, because the way that I see it in 3 to 5 years, if it's bad now, it's going to just get even worse.
Yeah, and our healthcare systems are facing the same trouble. So I lose sleep at night over not only primary care, but frankly more over Roger Williams and Fatima Hospice. Even if this deal goes through, I don't know that they're going to be around in a couple of years, given the way we structured.
Well, just how do you think we can work this out? Just for the low-hanging fruit, the real practicalities of some of the problems that we talked about tonight. How can we team up with the speaker to get this? You'll definitely meet with us. You'll definitely hear what everyone has to say and get the ideas across. What do you?
Yeah, I think. Look, I think the more concrete it is, the more likely we get him to listen. So what I would suggest is, and we'll come back to you, Doctor. What I would suggest you do, first of all, if we do have a meeting with them, either come back or send a friend, okay? Because we don't want them to come in and see an empty room, right? So that's number one. Number two, I would really encourage you to send us, me, the team, some of you haven't spoken a lot tonight, email us of 5 takeaways or things we could be doing differently or things that we didn't answer, things I said that were stupid. Trust me, I get plenty of that kind of thing. So I think that would be helpful. And then once the speaker clears the session, we could get another group, this many of us will come back and others perhaps come back.
He said as soon as he's done with the session, he'll meet.
That's great. Yeah. And Doctor?
So, first of all, I really appreciate everybody's comments. And I feel like I'm hearing what I feel when I'm working in the emergency department in terms of what's frustrating in terms of the work that you do. In terms of defining the problem in a way that's accessible to folks who think differently, i.e. not medical but legal, if you just want to give them, from my perspective, give them the word capacity, because we don't have enough primary capacity in this state. You're hearing the frustrations from everybody here about that. We can't get the job done, we can't see all the people. What I live is that I can't get people to new primary care doctors. I can't tell you how many people I see coming through the emergency department who do not have a primary care doctor, and I cannot get them one. There's nobody I can call, there's nobody taking new patients, and it's not limited to primary care. I get somebody comes in with chest pain, I rule them out, they're safe to go home, but they should probably get a stress test. I can't get them in the Joe Mazza's practice or anybody else for weeks to months. Okay, there are no urologists who cover Newport Hospital. Anybody who's sick,
on call.
On call, but anybody who's sick from a urologic standpoint cannot get admitted. They have to get transported up to Providence.
Failed recruitment for the last
So
3
capacity,
years.
so it's capacity in all these different areas. So if you want a target to get to track capacity for primary care, track capacity for your specialties. How you get there, that's what these solutions, you're gonna have to figure out how to get there. But if you want to give the speaker something to target the capacity for us to take care of the people of Rhode Island.
Let me just end on this. First of all, I think if any of you want to sort of spend a little more time with us, like Hub does and Dr. Sullivan does, we would love to have your participation. I know how busy you are, so I'm not asking you about you. I guess I kind of am. But to the extent you want to become kind of a core group to kind of help and inform our team in this process, we would love to hear from you. On the other hand, you can't find time in your busy schedules, I totally respect it. That's number one. And because it's after 8, I think I've forgotten what number 2 is.
Can I ask a quick question? This goes back to some of the points you made, Dr. Percola. What are when we're talking, just to bring it back to kind of health outcomes at the end of the day and the patient perspective, we all believe there's a crisis, and that will manifest in terms of negative health outcomes at the end of the day. What are the health outcomes that we should expect to see in crisis as a result of this capacity issue that we're facing?
I mean, failure to detect, failure to prevent. We see cancers diagnosed at more advanced stage. I care a lot about cancer. Everybody should. And prevention is two different things. So lifestyle, smoking cessation is true prevention. But the next best thing, that's also called secondary prevention, is catch it early. And so when people go to the emergency room and it cannot be seen, someone has symptoms and they cannot be examined, they cannot get a CAT scan, we will diagnose cancers at the more advanced stage. I think the public could relate to that.
Well, I did remember now, thank you, that was very good. I remembered what it was I was going to say. When I talk to Rhode Islanders, and I talk to them a lot, and I talk to them in bulk, ballroom size groups, they get this. They get the primary care crisis because they're feeling it. They get it. And I think that will help too over the next, short and longer periods of time. But it's reaching the point where when you bring it up, I can see them out there nodding their heads. They get it. They get it. When I ask them, how many of you can't find a primary care doctor? A lot of hands go up. A lot of frustration. They know that Shelley and I are married, and they ask if she'll see them.
Yes. Can I just say one thing we didn't touch on, because I think we've all given up, is malpractice reform.
Yes.
A lot of consults, a lot of tests, a lot of has been done because we're afraid to lose our house. So that's and I really do think we've all just given up. It's like, oh, it's never gonna happen.
Well, it's damn lawyers. All right, thanks everybody.
Thank you very much.